Enterprise Institute. I am also a consultant. I make my living advising life sciences companies, just to be fully transparent about the many different places I've worked. I'll be moderating, and do work today. I'll be moderating our panel today entitled Medicare Advantage, Growing Pains or Just Growing Up. We'll be talking about the evolution of the Medicare program, and in particular, how Medicare has evolved to include now just over half of its beneficiaries in Medicare Advantage. In just a moment, we're going to kind of do a quick primer on what the difference is between Medicare Advantage and Medicare Fee-for-Service. But I'm going to start by asking each one of my panelists to please introduce themselves and tell me why we invited you, Brian and I invited you to be on this panel today. So I'm going to start with Alyssa, please.
Alyssa Polisi. I have spent 11 and a half years advising various members of Congress and committees on the Medicare Advantage and Part D program.
Hi, I'm Lisa Grabert, a visiting research professor at Marquette University. And I think I may have been invited because I've dedicated the last 3 years of my life to a dissertation that's looking at the difference between Medicare Advantage and Fee-for-Service Medicare.
I'm Brian Miller, associate professor of medicine and practicing hospitalist at Hopkins, non-resident fellow here at AEI. I'm interested in Medicare because I want Medicare to be around for the next 30, 40, 50 years. I think it's a sacred promise that we made to our citizens who are elderly and disabled or who end up in those categories. And I want to make it more convenient and accessible for the actual end user, which is the beneficiary. I should also note that I serve on MedPAC, and my views are my own and not necessarily those of any commissioners or of MedPAC.
Thank you so much. And just as a reminder, we're also broadcasting this, and if the session's being recorded, it'll be posted on our YouTube channel. So please be aware of that. And I'm gonna start off with a clip that sort of sets the tone for a bit of the policy debate in Medicare Advantage and Fee-for-Service right now, particularly when we consider the fiscal implications of Medicare Advantage. So I'll go ahead and run the clip.
We're both fans of MA plans, whatever the shortcomings, but there's some evidence they're getting anywhere from 106 to 120% of a group of similar Medicare patients who are not enrolled in MA. And now, as we look at the trust fund going insolvent and our budget deficit expanding, is this a place you would look? And if so, how would you look in terms of getting better value for the dollar?
Thank you so much. So with that backdrop, Brian, can you please explain what is the difference between Medicare Advantage and Medicare Fee-for-Service? Give a little bit of the trade-off for beneficiaries and for doctors, why an individual might prefer one over the other. I realize this clip has set up some of the financial differences, so a policymaker may prefer one or the other, but tell us why a doctor or a patient might prefer Medicare Advantage over Fee-for-Service and why.
So the Medicare program is over half a century old. For those of you who are not familiar with it, there's Part A, Part B, and Part D. Simplified terms, Part A is hospital costs, Part B is doctor's services, and Part D is drugs. And I guess you could say that after multiple tries, the policy community finally got it right with D for drugs. If you enroll in traditional Medicare, it's the best of insurance design from 1965. It is an any willing provider network, which means that if the physician hasn't committed a felony, they are part of the Medicare provider network. So it's a very broad network. In 1965, people did not incur as many medical costs, so there's no maximum out of pocket as part of traditional Medicare. There's co-pays, co-insurance, there's a Part B deductible. And so many beneficiaries, obviously by the time you qualify for Medicare, either at age 65 or due to a disability or one of the disease-specific entitlements, you have a lot of expenses. And with no maximum out of pocket, many beneficiaries get something called Medicare supplemental coverage, or you could call it a WRAP plan. And so that comes from a couple sources. That comes from either Medicaid, if you've spent down your assets and become qualified for Medicaid, comes from retiree health coverage, or it comes from purchasing a regulated Medigap plan in the private market through one of the standardized benefit designs. Then on top of that, after paying your Part B premium, so there's no Part A premium, you pay your Part B premium, you pay your Medigap premium, and then you pay your Part D or prescription drug plan premium. And so if your Part B deductible is around $174 a month, and then your Part D, and that's income, can be income adjusted, and your Part D deductible, or Part D, sorry, premium is around $40, $50 a month, and then you have to buy Medigap coverage, which is several $100s a month. That's a pretty expensive out-of-pocket for someone who's on a fixed income or on Social Security is their only source of income. And so I know some of my colleagues will talk about the MA bidding and benchmark system, but in Medicare Advantage, you have the option to pay for a Medicare Advantage plan, which usually is your Part B premium plus a small amount or no additional premium, and you get Medigap coverage included and Part D coverage included. The trade-off, though, is that you accept more utilization review and you accept a network, either a preferred provider or an HMO network. So the fundamental trade-off is more providers, more monthly cost, and constructing your own benefits package or buying a unified benefits package at potentially a lower monthly out-of-pocket premium cost and getting those additional Medigap and Part D coverage. So it's sort of a access and benefits trade-off. Like, how broad do you want your network and how much do you want to pay for those additional benefits, which you need, right? Because if you're 65, you're 75, and you have health problems, going without prescription drug coverage or going without Medigap coverage is, medically not reasonable as a benefit for most beneficiaries. And so that's the trade-off that beneficiaries face. For clinicians and for health systems, right, fee-for-service is easy, right? You do the service, you meet the diagnosis coding, the billing requirements, and you're paid within 30 days. In Medicare Advantage, you might get more or less, depending upon what the negotiated rates are. You could get tiered in a provider network, and you could get, subject to prior authorization and other utilization reviews. So health systems and doctors generally prefer fee-for-service due to ease of payment. For beneficiaries, it depends upon how they are constructing their benefits package and how much money they are able to or are willing to spend.
Thank you so much. So my next question is going to be for Lisa, especially following on the comments from the hearings that led for Dr. Oz. Explain to us why there is this 106% to 120% estimate. How does bidding work in Medicare Advantage? How does the benchmark system work? How does a doctor get paid more or less than they would in fee-for-service?
Sure. So Brian did a nice job of covering the beneficiary and physician perspective, and I'll take a little bit of the financing perspective. So the Medicare Advantage program is set off of what's actually done in fee-for-service spending. So at the county level, there are something called benchmarks that are calculated on fee-for-service spending, and then Medicare Advantage plans will actually submit a bid based off of that fee-for-service metric in a county. If there is a differential between the bid and the benchmark, then the Medicare Advantage plan has some rules about what they can do with that additional money. There's something called the medical loss ratio, or the MLR, that dictates what they can actually do with that money, and the vast majority of it has to be invested back into the Medicare program, typically for Medicare beneficiaries. So if there is a delta between that bid and the benchmark, Medicare Advantage plans will often offer to beneficiaries, the vast majority of which is reduced cost sharing. So reduced premiums and reduced cost sharing associated with individual services that they have. So financially, sometimes that means when a beneficiary goes online and wants to select between Medicare Advantage versus fee-for-service, they are often shown a lower cost for enrolling in Medicare Advantage based on what Medicare Advantage can offer due to that bidding and benchmark system. As Brian mentioned, some fee-for-service beneficiaries may opt to do Medigap as a wraparound, especially when they elect that service, they're paying much more out of pocket for getting their benefits under fee-for-service versus Medicare Advantage. The way that individual plans manage those fees that they get from the federal government is they're basically given a per member per month payment to manage all of the services that they give to those individual beneficiaries. For providers and physicians that negotiate rates with plans, they're usually paid pretty similar to where fee-for-service is. So there's not a lot of difference in what the Medicare Advantage plan pays versus what the Medicare program would pay for an individual provider from fee-for-service. So there's not really a differential there, but there may be a differential for the beneficiary in terms of what they see. So in addition to investing in cost savings for beneficiaries and what they offer, Medicare Advantage plans can also use some of that money to offer different services to beneficiaries. These are typically referred to as supplemental benefits in the Medicare Advantage program. And many times beneficiaries are offered dental, hearing, and vision. They may not be offered those things in fee-for-service Medicare. If they elect one of those Medigap plans in fee-for-service Medicare that offers those services, I think there's 2 Medigap plans that offer some of those services, the vast majority of fee-for-service beneficiaries are not getting those same level of additional services on the fee-for-service side than they would in MA.
Thank you so much. So Alyssa, I'm going to turn it over to you now and ask more of a political or a policy question. You worked on Senate Finance, Senate's budget, House Ways and Means committees. Where are members of Congress on the Medicare Advantage program, both on the plus side and the minus side?
That's a good question. From my time on the Hill, I think there were a lot of members that were more focused on fee-for-service, for sure. Lisa and I were colleagues on the Ways and Means Committee, and I think her portfolio definitely got a lot more attention from members than the Medicare Advantage and Part D portfolio at the time. But now with the growth in MA, I think we're seeing a lot more members hearing from constituents, hearing from advocacy groups, and it's drawing a lot more attention to the program itself. I would put members probably in 3 categories, the first of which, you have this contingent of members on both sides of the aisle that are supportive of the Medicare Advantage program. They understand the value compared to fee-for-service, but they want pragmatic reform to the program. They want to realign some of those incentives and go after program abuses. And I think even this nomination hearing was a really good example of, hearing from some of those members. And that group should be supported, as they're trying to thread that needle on program improvements, having to balance the need from a variety of stakeholders that engage with the Medicare Advantage program. Then we have some members, again, on both sides of the aisle that seemingly want to dramatically change the incentives and or make it look more like fee-for-service. These are definitely the louder voices, unfortunately. And while many of those members likely don't have the intent of making the program look more like Medicaid or look more like the individual marketplace, many of the proposals that I've seen be introduced in Congress do just that. And there are consequences to some of those changes that I think need to be, thought through more before sort of they gain more steam in Congress. And then lastly, there is a good number of members that truly are not familiar with the program. And this group does need education. They need education on the origins of the program, as well as some of the changes over the years and the impacts of those changes, not just to benefits, but also to plan competition. And I can't say that the group of those that want to see dramatic change to the program has grown over time. We are seeing more Republicans join that group, but I think they're just becoming more vocal. So that's sort of where I think members are, and there's obviously variations, and folks have their own different spin.
That's a very good, quick overview of a lot of divergent points of view. And so to follow up on that, to Lisa, let's say Medicare Advantage is sought out as a source of savings. Let's think about what could be on the chopping block. There is a performance measure called a star rating, and maybe you'll give a quick overview on what a star rating is. They're often described as a handout to plans rather than an incentive to deliver quality of care that is appropriately compensated. What do you think might be done to modernize or to reform the STARS program so it is really a value-based payment if, in fact, you think it needs reforming?
Sure. So let me talk a little bit about what the STARS program actually does. So for Medicare Advantage program, there are roughly 40 STARS measures that are across several different categories. They may look at something as specific as a readmission at the plan level, so people who have an inpatient stay but then are discharged and come back for some reason, but they also include things like patient satisfaction. So how satisfied were patients when they receive services, and how do they rate overall the satisfaction with their Medicare Advantage plan? There's a large range of the individual measures. The way that the STARS program is set up for Medicare Advantage plan is it's a bonus-only program. So there is no downside for poor performance. You don't get penalized in any way. But if you do perform well, and it uses, I should say, also a 5-star system, but if you perform well in the 4 to 5-star range, you can earn bonuses. I think the most recent figure of what's been paid out on an annual basis for the STARS program is roughly $12 billion. So it's quite a bit of money that's paid out to individual plans for achieving top performance compared to their peers. The interesting contrast between what we have in place for Medicare Advantage is, on the fee-for-service side, there are also quality programs. There are about 15 different quality programs on the fee-for-service side because they are all done and administered at the provider level. So on fee-for-service, you have hospital measures, inpatient and outpatient, 2 different quality systems. You have measures for physicians, nursing homes, home health, all different sets of measures. Almost all of those programs are both bonus and penalty programs. So if you are not performing at a certain level compared to the national benchmark as a provider, you will be penalized. But if you are performing at a higher level, then you will receive a bonus. On the fee-for-service side, a lot of the programs are typically budget neutral as well. So they're not adding to the deficit on an annual basis. That's another difference with the MA bonus program. The $12 billion is not budget neutral, so it can change, it can grow and shrink over time. So that's a possible area of policy reform that legislators could look into for STARS bonuses. One of the biggest criticisms I have as a policymaker is there's no way really to compare across fee-for-service and Medicare Advantage. We don't have a way to do an apples-to-apples comparison for quality measures in that program. And if we did have a way to measure and had similar measures across the 2 programs, it would be great for beneficiaries. So imagine yourself as a beneficiary going online to make these decisions about whether or not you want to choose Medicare Advantage or fee-for-service as your coverage option. You are shown information on your annual out-of-pocket costs. You're shown information on whether or not supplemental benefits are available, but you're not given any information on the level of quality of services you would receive for one option versus the other. That would take quite a bit of policy building, as I sometimes like to say. In wearing my former hat as a Ways and Means staffer, I don't perceive that CMS, the Centers for Medicare and Medicaid Services, doesn't have the authority to do it. So if they wanted to, they could implement such a system and begin building it tomorrow without authorization from Congress. But I think that's one area that I would encourage lawmakers to look into, maybe stimulate and get the administration to actually make an investment in having comparable measures across fee-for-service and MA, so we can begin to answer the critical question of, if we think that there is a payment gap between what the federal government pays for Medicare Advantage versus fee-for-service, we have financial information, but we don't know anything about the quality of the services given out. And without that second component, it's really difficult to say more money is going to one side or the other when we don't know what the quality of the services are.
Yeah, and I would add, right, we shouldn't make choices just based on cost or quality. It's cost and quality, because the quality of care that beneficiaries get access to matters a lot. And so at a county level, if we had a star rating for the MA plans and also the fee-for-service plan, and the plan options had a 2-sided risk, as Lisa pointed out. One, if they did well, they could get more money, and then that would flow through to the beneficiaries as additional benefits, which I think makes sense. And if they did poorly, right, the plans would be financially penalized and still be required to deliver the same benefits to the beneficiary. So it would hold the beneficiary harmless from harm and then force the corporate or plan enterprise to either perform or not perform. And then some in the industry might be concerned that that is a huge change, and actually it would be an incremental step. Because right now, if your star rating drops below a certain amount, your plan is put on probation from enrolling new beneficiaries, and if it continues to perform poorly, then you are not allowed to participate in the MA plan market. The contract eventually gets terminated. So this could be an initial step of a financial penalty, then not being allowed to enroll new beneficiaries, and then being ejected from the market.
So Brian, take us back as a follow-up with you on Dr. Cassidy's comment, without getting too much into the methodology, but as I understand it, the difference between Medicare Advantage getting paid 106% of fee-for-service and 120% of fee-for-service is largely methodological change. Maybe just explain this number in plain English, and then I'm going to ask Alyssa to follow up with you on a little more of the implications for how this might affect policymakers' views on needed reforms in Medicare Advantage.
So noting that my views are my own and not those of MedPAC, the concern is that there are two primary issues driving differential payment. One is favorable selection, and then the second is something called coding intensity. And taking those briefly, the idea is that plans are either enrolling healthier beneficiaries or they're enrolling beneficiaries within a disease category that are lower cost than the ones in the fee-for-service. I think that there are probably arguments on both sides of that, right? Because there is some evidence that plans are doing that. But then there's also evidence that plans have negative selection into the plan market. For example, the inclusion of a maximum out-of-pocket cost in the plan, in the MA plan market, which is a regulatory requirement. It's not a regulatory requirement in the fee-for-service market. If that were implemented in the fee-for-service market, for example, that would increase costs by 2.8% through an actuarial study that was produced. So I think on the favorable selection, it could go either way, and it probably depends upon the plan participant. Mm-hmm. The coding intensity argument is an interesting one. So I'm a physician and I practice, and when you're I do hospital medicine, when you see patients in the hospital, you do some diagnosis coding, right? Because there's a principal diagnosis and there's a secondary diagnosis. And then sort of after that, diagnosis coding doesn't really matter for hospital payment because the hospital doesn't get paid differently. And if you're in the outpatient setting seeing someone, you're either paid based upon time or something called medical decision-making, which is about risk and complexity of decision-making and data analysis, which again has some component of diagnosis coding, but not a lot. And so you could imagine, and there's some evidence that shows that the fee-for-service market is undercoded, meaning which makes sense because your payment is not tied purely to diagnosis coding. In the MA market, you get the plan does a capitated per member per month risk-adjusted payment. And that's tied to the diagnoses listed. And so you can imagine that a health plan has a natural market incentive to make sure that it codes diseases that address payment, complexity of the disease, and the severity of disease. So it's not surprising that there's a differential coding in the MA market versus in the fee-for-service market. And so then your question is, well, is all of that coding appropriate? So I'd say there are probably three buckets, and we haven't measured those buckets. There's what I would call clinically appropriate coding intensity. So if you're a diabetic patient, and I say you have diabetes complicated by neuropathy, nephropathy, and retinopathy, right? So nerve damage, kidney damage, and vision damage from diabetes. That's an appropriate differentiation because that diabetes patient, if I just say you have diabetes versus you have diabetes with all of these complications, that's a very different patient, right? Clinically, the patient who has all these complications needs to see a nephrologist, they need to regularly see an ophthalmologist, they probably need to see a podiatrist, they need to do daily foot checks, there are all kinds of implications for their care. That's probably clinically appropriate coding intensity. Then there's what we would call the gray area of coding intensity, which is sort of on the border. And then there's what we would call fraudulent coding intensity, which is I'm coding a disease that you don't have, right? So in the first bucket, that's a good thing. We want doctors to be coding diagnoses appropriately because that's good clinical communication. In the latter bucket, the DOJ should be sending a black card to pick you up and take you to a place, right, called jail. The middle bucket, people can debate, and they should debate. And I'm probably more conservative, so I would say don't do that. But reasonable people can debate. We don't know what those three buckets are. So I would say for the debate on Medicare Advantage versus fee-for-service, like Lisa said, it's about cost and quality and what the benefits the beneficiary is getting. I don't think any of us want the government to overpay Medicare Advantage plans, right, and misuse taxpayer dollars. And there's probably a couple percentage points in there where there is overpayment to some plans. But that doesn't mean that all plans and the entire market are overpaid.
Thank you so much. So then, Alyssa, I'm going to ask you a little about the implications. Often in health policy, someone will change the methodology, and the narrative is, oh, the overpayment went from 6% to 20%, which, as Brian just explained, it's not necessarily the case here. So let me ask you, how has the change in methodology resulting in a bigger estimate of the differential affected viewpoints about how Medicare Advantage should be managed or whether there should be reforms to the program?
Yeah, I think obviously the shift from, a MedPAC perspective going from 106 to 120 is pretty big. I don't know that lawmakers are looking at where they're at currently, the current methodology, and saying this is for sure what it is and we need to address, this gap. I think it's obviously raising, attention, getting attention. I don't know that you can, just do a direct cut at that level and not expect benefits, competition to be impacted from a cost perspective. So again, it's getting attention from lawmakers, but I don't know how seriously that specific number is being taken. And again, when you look at the methodology and there being maybe some insufficient data to support what has been rolled out, those are the questions that are sort of being asked right now on the Hill.
So this is a question for Brian. Why couldn't lawmakers say, let's use artificial intelligence to figure out the gray area and that you ought to be in jail coding as a way to save some money?
So I have a thought on that, but I want to respond. So one of the things I think policymakers are, at least from I hear in my conversations with them, which I agree with you on, I think there's some questions, is that Medicare is a benefit that people are currently receiving. It's not a hypothetical benefit. If you're retired, right, you're probably, like if you're 75, some 75-year-olds are in the workforce, but if you're 75, you're not in the workforce most likely. You probably have limited net worth and limited assets, and you probably have a very fixed income. And so any change that's significant to the Medicare Advantage or Medicare Fee-for-Service program, this doesn't mean that they both don't need improvements, but any significant change needs to make sure that beneficiaries are appropriately protected and that reforms are practical, cost-effective, and preserve access and preserve quality. And so coding intensity is actually one of those areas where we could stop the argument and actually solve problems. So for 30 years, you can go back into the economics and health services and health policy literature and find people arguing about Medicare Advantage coding intensity. They could, going back to the 1990s, people were saying that the predecessor to Medicare Advantage was overcoded. And then on the other side, you'd have people who would say, no, it wasn't overcoded, fee-for-service was undercoded. And then you'd find other articles that say something in between. And the answer is yes, we can all continue to sit around and construct models and write papers and argue about it, but then we actually, one, haven't answered the question, and we can have more panels and more coffees, which is great for all of us because it'll keep us in business, but we want to solve problems for beneficiaries and policymakers. And so the inherent question is, I went to medical school and residency and graduate school, And I used to teach diagnosis coding, but do you really want to use my clinical brain to code diagnoses in the chart? Like, is that a good use of doctors' time? We have a shortage of clinical access for Medicare beneficiaries. Do we want doctors, nurse practitioners, and physician assistants doing diagnosis coding? I have software on my iPhone which will tell me, the coder can send me an inquiry telling me that, this patient was not coded appropriately. Like, do we want to use our clinicians' time to do that? Or do we want clinicians serving Medicare beneficiaries? My answer is I want the doctor serving my aunt. I don't want the doctor typing at the computer and, writing in diagnoses. And I also really don't want us to have thousands of policy panels arguing about diagnosis coding and methodology. It's frankly sort of a waste of our time. We should be solving problems for Congress and solving problems, most importantly, for beneficiaries. So we have great ways to automate this. You could imagine a world where CMS, either Congress pushes CMS or CMS does it on its own, and pushes health plans, health systems, and doctors to use co-pilot type software, which combs through the chart, combs through labs, combs through imaging reports, and suggests the list of appropriate diagnoses, right? We don't need to remind every internist that you have CKD stage 3A or CKD stage 3B. We don't need them to look at the chart to find the GFR cutoff. What we need is software to tell them, and then they review it and check the box, either agree or disagree, and delete or modify the codes appropriately, which takes a couple seconds rather than doing it themselves. So if we pushed CMS to have plans, doctors, and health systems do this, then you could automate diagnosis coding across fee-for-service and across MA, which would then address concerns about coding inflation when people switch from one program to the other. It would address concerns about differential payment, and it would allow us to see what the beneficiary's disease status looks like across programs. And then we could stop doing models and start solving problems.
One thing I would just add, the question for Congress based on some of this MedPAC data is sort of, should MA and fee-for-service be compared? That is a question when you have two very different programs. And if so, what are the measures by which they should be compared? And I think Congress would need to get on the same page in terms of what is of value to them in comparing those two programs and have MedPAC run the analysis in that manner.
And I would say an important question is, right, if you're a beneficiary, again, if you're 75, you're 80 years old, like, you need prescription drug coverage. It's not really optional, right? Like, you're going to have, there are very few, 75, 80-year-olds I've met who have no health problems and take no prescription drugs. I hope I end up as that person, but that ship has already sailed for me. So, you need prescription drug coverage. You need some formulation of Medigap coverage, whether it's retiree health insurance, whether it's Medicaid, whether it's Medigap coverage, whether it's something else. You need a whole benefits package. So I think one of the things that policymakers want, and I think would be good information, is what is the per component cost, right? Like, what does it cost, not just across fee-for-service A plus B and MA, which is A plus B plus D plus Medigap, but what is the per beneficiary Part A cost? What is the per beneficiary Part B cost? What is the per beneficiary Part D cost? What is the per beneficiary Medigap cost? So look at the holistic components or holistic program, and also the per component costs, right? So that we know what those trade-offs are, because at the end of the day, society is paying for the entire health benefits package.
Yeah, Kristen, I'll just add to sort of what both Brian and Alyssa said. One of the things we don't know today is, as Brian mentioned, the cost. I might say we don't know the value of some of the things that are offered on the different sides of the program. So Brian mentioned trade-offs of prior authorization and more narrow networks. That has a cost to the beneficiary in terms of what they receive. You can put an actuarial value to that, and we could put that equation in place and then start to compare. On the fee-for-service side, you can see any provider you want to. That has a value to the beneficiary. You can put an actuarial value to that, but they don't benefit from an out-of-pocket cost. So they don't have those protections on the top end. That also has a cost to the beneficiary. So we can look at the difference between the values and the cost between what's offered, and that should be taken into consideration as well. I started with quality and how we don't have any information on quality. That there's a value placed on that as well between the different parts of the program. When you start to break down all of those components that are missing in the MedPAC analysis, when they're only looking at cost, I think you come a lot closer to the question that Alyssa asked, should we be comparing these things at all, since we really don't have any basis of similar comparison in which to make that kind of judgment?
Well, and to ask, so in a lot of the quality metrics or process metrics, is there a way to look at health outcomes between the two programs or people with similar diagnoses in the two programs? This is a question for Lisa.
Yeah, there certainly are. I mean, and it really comes down to who's picking the measures and what they value and where they get that information from. So a lot of times the bureaucrats at CMS are picking the quality measures. When I was a staffer and I worked on the Ways and Means Committee, I saw what the administration was picking. And so I took what I'm sometimes told is the bold action of actually codifying quality measures in the Social Security Code. Because if we know what matters to patients, I would empower members of Congress to start to pick some of those measures themselves. When you just give all that authority to the agency, you probably shouldn't be surprised that we have over 500 measures for physicians to pick from on the fee-for-service side. That's what happens when you give broad authority to the implementing agency. If that's not the outcome that members of Congress want to see, they have to be much more specific about what is truly of value to both beneficiaries and the taxpayers in the Medicare program, and start to maybe codify specific things themselves in statute.
Right, because when you have 500 quality measures, you can pick the quality measures that work for you. Those quality measures top out, right? Quality measures become outdated, they might be less relevant for your population, and having a smaller number of quality measures, which is then less administratively burdened for both the market participants, whether it's the doctor, whether it's the hospital, whether it's the health plan, and also the regulator, and then you can make more meaningful decisions because you have a narrower, more specific, more well-tuned universe of quality measures.
And on the process measures, there are a significant number and emphasis on process measures in MA and Part D in the Star Ratings program. And some of those process measures are outside of a plan's control. So you look at some of the contention between providers and the MA plans or pharmacies and Part D plans. A lot of those contentions can be derived from specific quality measures that are in place today. Just on the Part D side, you have medication adherence and measures, where you maybe see then plans putting some downward pressure on a provider or on a pharmacy as a direct result of something that CMS has created to say we're going to measure plans by. So the quality measure system that's in place for MA and PDPs has obviously proven to be a very strong incentive system and is driving plan behavior. And then there are the downstream effects of those quality measures. So to Lisa's point, I think there's a lot of room for congressional conversation and discussion over what they want that quality program to look like, but then also looking across, even fee-for-service, fee-for-service and MA, there's just different quality incentives in both of the programs. So if you're driving towards like one goal across Medicare beneficiaries, some would think you'd want those fee-for-service measures that providers are dealing with to more also align with what the MA plans have.
And ideally to align with what patients want as well.
Yes.
A couple thoughts on that. So one is, I think when you have devolved too much authority to the implementing agency, people get confused about what a quality measure is, right? There's basic performance of things you should do so that people are not harmed, people are not killed, basic processes are followed, right? Those are not performance measures. Those are basic things that a health system, a doctor, or a health plan should do. We should know what those are. And then we should have the actual performance metrics be tied towards a bonus, right? Like a narrower universe of things that people are supposed to target across fee-for-service and MA, because you want that beneficiary to have, they're going to have a different experience with different benefits or different doctors or different hospitals, but you want the measured outcomes to be the same across. An example would be, for example, if we measure prior authorization, right? You could imagine in fee-for-service that prior authorization would be scored much less burdensome because there is very little in fee-for-service. There's more prior authorization in Medicare Advantage, right? So maybe some of the plans would do very well with that and some of the other plans might not do as well. But then you could also look at something like the richness of the benefits package, right? In MA, the MA plan might do better on, say, covering out-of-pocket cost sharing, whatever it is. And so you want beneficiaries to have meaningful metrics of what those trade-offs are that are useful to them, useful to the delivery system, the plan, and the regulator, and not have 500 metrics to choose from.
Thank you so much. So all of you who braved the rain to come here, I'd like to open up to questions from the audience first, but if you're online and want to submit a question, I can also take it here. So is there anybody in the audience who wants to pose a question to one of our panelists? Yes, thank you. And I think Jack's coming around with a microphone, so everyone online can also hear your question.
Yeah, hi, Larry Bouchon from Holland and Knight. The question is, and a physician also. The question is who should be putting diagnoses codes on patients' charts in MA plans? Should it be everyone? Should the plan? Should the physician? Should the patient suggest those? Because one of the points of contention, I think, that you're seeing in MA plans, at least in the Congress, is that there are diagnoses codes being added to patients' records, in some people's view, that are not clinically significant and that their own physician wasn't aware was on their chart.
Maybe Lisa, can I ask you to take a
I was going to say,
first
give that one to the doctor.
I know, but I want to ask not the doctor. Because I think there's a question about should not the doctor be putting diagnosis codes on?
I mean, I guess from my perspective, if it's just for MA, the original intent of Congress was to have a hands-off approach in how the Medicare Advantage program is run and implemented and offered. So I don't know that they necessarily need direction on who should and should not be coding things would be sort of my first. But I do think the question is more appropriate for a clinician.
Okay, Brian.
So I'm obviously a biased market participant as a practicing physician, but I would say if you had the co-pilot model across the delivery system, chart reviews, the home health risk assessments, those controversial areas of adding diagnosis codes to beneficiaries' charts probably wouldn't matter and would go away naturally because you'd have more complete coding at the point of care. So, and this is not to punt the question, it's really to say those models wouldn't be necessary. Again, going to the ethos of, as opposed to regulating a specific business or contracting type behavior to solving the broader problem.
Thank you.
There are financial implications to the taxpayer based on MA plans based on what codes are on a patient's record.
That's right. And so if we automate the diagnosis or most of the diagnosis coding across the entire Medicare program, that would solve that problem.
Any other questions?
And I would add that automation, when it occurs at the point of care, would occur with a physician, with a nurse practitioner, with a physician assistant by design.
Or possibly with a patient survey, right?
Or with a
Why
patient
should the patient
survey,
not be involved in there? Yes.
Gerald Chandler from Alexandria, Virginia. Could you make some comparisons to various different European systems? I would say that the NHS is sort of like Medicare Advantage, and the German system is sort of like fee-for-service. And do they have these considerations? Have they discussed it? And do you agree with whatever conclusions they've reached?
Oh, great question. Who wants to take that one?
Lisa.
Brian?
Lisa.
I mean, generally, I would agree. I do think that MA looks more like the NHS and fee-for-service looks more like the German system. I don't know that I have much else beyond that.
I thought of it more the other way.
Isn't that what he said?
No, I thought of it as more of the German system is more like MA and the
Yes,
NHS
that's
is
what I
more
meant
like
to say.
fee-for-service.
Yeah, that's what I meant to say.
So I think that all international comparisons, well, one, thinking about different health status, different culture, and different habits driving different health outcomes, I don't necessarily think that the fee-for-service or the MA system is necessarily better on their face. I think that the important thing in the US is that the beneficiary has a choice, right? Because there are trade-offs on cost and access. If I have an any willing provider with fee-for-service, that can be very expensive, and there's little way to direct quality and direct utilization, right? And if in MA, like, you might get too much utilization and too much direction, and the answer for many is probably somewhere in between. At least for me, I would say I think the best is for beneficiaries to have the choice across that and not to be forced into either fee-for-service or an MA model.
Let me ask you a question then following up on choice, because I've studied this in the prescription drug market, the MAPD plans versus the standalone. And as the standalone plans have exited the market, we do see unequal access. In rural areas and lower income areas, there's not as much choice. So does every person, every Medicare beneficiary across the country have choice to be in a Medicare Advantage plan? And I guess I'm going to put that first to Lisa. And are the choices sort of equal if you're in an urban area versus a rural area, for example?
Yeah, so choice is certainly more limited in rural areas as opposed to urban areas, but there still is enough choice. I say, who is the arbiter of whether or not there is enough choice? I guess I can point to the Medicare Payment Advisory Commission, who recognizes that there is enough choice for individual beneficiaries. There are a few plans in some areas, and in some areas, some people might argue there are too many plans as well. There may be in excess of 40 plans offered in a specific county. So choice is sort of in the eye of the beholder. People will argue both ways. There's not enough choice, there's too much choice. Every different economist you talk to will argue whether that's a good thing or a bad thing. But I do think there is enough choice out there. In addition to choice, I think what we want to see as policymakers across the Medicare program are people electing the benefit and the management of the benefit between fee-for-service and MA that best suits their individual needs. And that's where I think we still need a lot more research to understand how individual beneficiaries are making choices, what things are predictors of their choices, and if in the end, actually asking beneficiaries themselves if they feel like they've opted the right thing and it's meeting all of their needs. So we need a lot more research understanding all of these things about the choices that beneficiaries are making.
Thank you.
I was going to say beneficiaries also make choices in a variety of ways. A lot of people make health and health purchasing decisions in conjunction with their spouse or partner, their grandchild, their friend, and so that's an important weigher on choice and partner. So it's often not necessarily just the individual. People also make choices in conjunction with independent counselors, which I think is something that has historically been paid less attention to by CMS over the preceding years and decades. Not from any one particular administration, but just in general, that has not received as much attention. The Plan Finder, which I know something Lisa has done some work on, is something that also I think is due for more time and attention so that beneficiaries can better shop, right? If you're in the ACA exchange market, you can go in and put in your doctors and put in your drugs and see if they are in network and covered. For Medicare, you can't do that with your doctors, but you can do that with your prescription drugs. That doesn't make sense. The Plan Finder also, you can't compare, constructing, again, that holistic health benefits package, knowing, again, if you are 65 or older or disabled and enrolled in Medicare or have a disease-specific entitlement are in Medicare, you need to know how much things cost. For a whole back package of A, B, Medigap, and D, you can't make that comparison in the current formulation of the Plan Finder. I think that is something that needs to be fixed.
Yeah, to Brian's point, the statistic put out by the Kaiser Family Foundation using Medicare survey data found for this year, 2025, coming into the open enrollment period, less than 30% of Medicare beneficiaries compared between their options to choose. So we do know that people are making choices based off of imperfect information.
Anything else from the audience? Yes.
Yeah, this is a pure clarification question. It was mentioned earlier that there was a change in the MA cost methodology. Some of us are not familiar with that.
Brian,
If
let's
can
go to you a
explain that.
question. Yeah. Do you want to explain the MedPAC methodology that changed the estimate from the payment differential from 106% to 120%?
Without getting too technocratic, and again, noting views are my own and not those of MedPACs, they changed the methodology by which they estimated favorable selection and coding intensity into a completely new model from 1 year to the subsequent year.
So it wasn't that payment rates changed, it was the estimate of how the payments differ between fee-for-service and Medicare Advantage changed. But I think some of the perception, and correct me if I'm wrong, was people heard that and thought payment rates changed, when in fact the measurement changed. Is that?
Yeah, so it was
fair?
the model changed as opposed to the actual dollars that flowed through the system.
No, thanks for asking that. Yes, thank you.
Hi, my name is Jan Bates. I have a question about quality of life for seniors. Is there any data collected by CMS or MedPAC or anybody else about how long current seniors have a good quality of life and whether their choice of Medicare fee-for-service or Medicare Advantage impacts
That's a great question.
the length of time they have good quality of life?
Who wants to answer? It's a great question. Who wants to answer that?
I would just point to potentially the beneficiary satisfaction surveys, and I don't know, Lisa, if they have something similar on the fee-for-service side.
Yeah, there are satisfaction measures on the fee-for-service side as well. I would also say, to your question on quality of life, I don't think we measure that very well at all in any aspect of the Medicare program. To a large extent,
Functional status, activities of daily living, put on a sweater, self-toileting, et cetera, and then independent activities of daily living. Can I go to the grocery store? Can I do a checkbook?
we do to a certain extent, right? So that's hyper-focused within the post-hospitalization measurement within fee-for-service. So there is activity of daily living, mobility, functional status for beneficiaries who had a nursing home stay or in home health or a comprehensive rehab hospital stay. But it's limited to those settings, and less than 20% of beneficiaries actually consume services in those settings. So it's not robustly measured in, at least on the fee-for-service side, and I don't think to a large extent it's robustly measured on the Medicare Advantage side as well.
And I think that's actually a really good point. So the sort of basic activities of daily living, can you care for yourself? And then the independent activities of daily living, measuring those at the population level and either the improvement or, not to be morose, but the decay of those over time across plans, across the programs and across plans, that could be a really good quality measure, right? Because people preserve, most people have a high priority on independence and quality of life. We should measure that. We should grade the health system on how it does to preserve or to prevent the decay of that. And that would actually move us towards sort of the population health goals that we've been talking about for 30 or 40 or 50 years and have not made that transformation. And actually, if you look at that, that is a completely non-political goal, because everyone from Sylvia Burwell, who was the secretary under Obama, to Azar, who was Trump's prior secretary, to, has functionally agreed that we need to go and explicitly said towards population health measures. And that would be a great place to start.
Yes, Jack, you decide who was up first.
So Adam Atherley, so my question for you is, as you're describing the risk adjustment issues with the payment methodology for Medicare Advantage, it seems like the fundamental problem is the administrative pricing scheme, where you essentially have the government announcing the price to the plans and then hoping that they won't game any system that is put in place. And the more precise the risk adjuster, the easier the system will be to game. And the Europeans have been trying this unsuccessfully for 30 years to really good risk adjustment system for an administrative pricing scheme. Is there any thought of moving away and more towards a true bidding type system and essentially get the government out of the business of setting the price for Medicare Advantage plans?
Who wants to take that one?
I mean, I guess I can jump on that bandwagon. Hopefully other people will follow me. Whether it's fee-for-service or whether it's Medicare Advantage, right, having a central authority set the prices is sort of Soviet, right? So we could imagine that the four of us up here set the prices for whether it's 9,000 physician services every year, thousands of hospital DRG and ambulatory payment and home health and skilled nursing facility. And we are probably going to, I think we could all agree that even though there's a pretty smart crew up here, that we're going to get a lot of those prices wrong, right? Too high, too low, cause access problems, cause quality problems. So that, I think we could agree that having the central authority set prices might not work so well in terms of the access and quality trade-offs, whether that's for skilled nursing facilities or Medicare Advantage plans in particular. Ideally, we would start to prepare the marketplace to move towards competitive benchmarks, right? You can't do that in one day or 1 year. We can't show up today and then tomorrow say, well, have competitive benchmarks, including fee-for-service and including Medicare Advantage. One, because it'd be massively disruptive to doctors, hospitals, plans, skilled nursing facilities, and of course, arguably, most importantly, the beneficiary. So I think to get there, we have to do things to prepare, right, that are practical and sensible. And Lisa and I have talked about this for years and even written about it. But one of the things that we could do for start is have a unified quality rating system across fee-for-service and Medicare Advantage. Risk adjustment, again, having unified risk adjustment, right? Why does the Medicare Advantage plan get a bonus for star ratings and risk adjustment, but the fee-for-service plan, which is a publicly run plan, but still it's a plan, why does that not get the star rating bonus or punishment, right, if they do poorly, or the risk adjustment, right? So moving the system towards similar gradings and sort of on a similar roadway would help us get there. So the answer is yes, but we need to do a lot of other things first, and we should do our homework.
Yeah, I would agree. Brian and I have publicly written in favor of implementing a competitive bidding system in which fee-for-service would be one of the options to also bid. Brian did a very nice job of articulating lots of smaller pieces over time that need to be put in place to fully get there and realize a system like that. And I think things like concentrating on a differential between fee-for-service and MA and coding adjustment and having discussions on 106% versus 120% are very distracting to getting towards those other things. So to the extent that we focus a light on hyper management at the micro level of comparing one fee-for-service beneficiary to one MA beneficiary, we are further away from the goal of getting to broader change that we need to see in the system.
Right, because then we're focusing on debating models as opposed to solving problems.
So thank you. I'm going to take one last question from the audience, then I'm going to ask the last question. So I saw you had your hand up.
Would you address the numbers or percentages of people switching from one type, fee-for-service, to Medicare Advantage, and the reasoning, if you know?
Sure, I'm happy to take that since I am actually doing a sticker and switcher analysis for my dissertation. So I'm 100% on top of the literature on that one. So basically in the Medicare program, we describe people as switching if in 1 year they had Medicare Advantage and moved to fee-for-service, and the next year, typically during the open enrollment period, although there are special enrollment periods in which you can switch, or if you move from fee-for-service to Medicare Advantage. Typically, the literature does not look at people who switch between Medicare Advantage, but that's an area that one of my colleagues pointed out to me earlier today, and something that needs to be studied more. So switching is typically defined as moving from MA to fee-for-service, fee-for-service to MA. It is a very, very small part of the Medicare population. There was a health affairs piece that was published by some members of the Assistant Secretary for Policy and Evaluation 2 years ago, and they found that the switching status ranged from about 2% to 7%. So it's a very small part of the Medicare population, yet it has received what I call undue policy attention. So a lot of people are focusing and worried about people switching back and forth, but in actuality, it's not happening very often between fee-for-service and MA. There are financial implications between people moving and the money that they take with them when they move between fee-for-service and MA. And that's something that policymakers have focused on. And another thing that's part of the sort of sticking and switching process is when we focus a lot on switchers because they're making a change, we sometimes forget the stickers. And the stickers are a much more important population to start to look at. So the people who stay with fee-for-service and why they stay, the people who stay with MA and why they stay, I find a much more compelling research question. My data is forthcoming. I will be defending my dissertation hopefully 4 or so weeks, and shortly after that, we hope, we can publish some of the research which opines on really trying to concentrate more on why people stay with their option versus why people are actually switching.
Maybe you'll come back and share it with us. So my last question, I'm going to start with Brian and end with Alyssa. Do you think this administration would support reforms to MA? And if so, one area where you think there would be a support for reform?
You know, obviously, I don't speak for the administration, but you know, as an independent person observing on the outside, I think there's definitely interest in reforming Medicare Advantage. I think they'll probably look to Congress for guidance. And I know that one of the things that Congress has looked at is the star ratings program. And so I imagine that that will probably be one of the first things on the shopping list for reform.
Do you want to go next, Alyssa?
Yeah, I mean, I think it's hard to tell which direction this administration will ultimately go, but I do think that the Dr. Oz nomination hearing gave a lot of really good insights into some of the abuses that they're looking to curb. Risk adjustment use through in-home HRAs, prior authorization. I think from a plan perspective, you have prior authorization being viewed as a waste, fraud, abuse tool. It's a blunt instrument, but has been useful overall for the program and for beneficiaries. And I think this administration is going to have to figure out how to thread the needle. But I think with Dr. Oz speaking very candidly about the reduction in services that should be that prior authorization should be applied to, greater oversight is definitely one of those areas, and then the in-home HRAs, again preserving sort of like the use of those in-home HRAs.
Say what an HRA is for us.
The in-home, the in-home HRA risk, home
Health risk assessment.
Health risk assessment. Thank you. So those in-home HRAs are used though for care coordination, and I think what he put a very specific point on is the fact that those in-home HRAs, while important, should be used as a care connection tool, and I think that is something that they're likely to focus on, hopefully.
Thank you. Lisa?
Yeah, I certainly hope that this administration takes a good look at Medicare Advantage, and I'd strongly encourage them to look at what they can do within their existing authority, because they have the authority to do many of the things that we talked about today. They can actually start to change the tools that are available for beneficiaries for making decisions. That's all within their authority. Tweaking the type of information that we educate people on when they make important decisions between fee-for-service and MA. They can start and they can revamp all of the quality measures. That really doesn't take an act of Congress because they have very broad authority there. So I would just encourage them to look at what they can do on their own and encourage them to start doing it.
Thank you so much. Thank you all. Have a great afternoon.